So what we are going to be, I would be showing here is something new which has probably been used in adults, but probably never had a chance to use in children probably in the world. Because so this is something, a drug which was brought up by Entod, and it's been used in UK for quite some time. But yes, in children, probably this is the first time we use it, and I'll just be showing you some of the, you can say the magic it has when you're dealing with the children with cataract who need to undergo surgery, and how effective it is. So I would be talking about the ICAM in pediatric cataract surgery. I have no financial interest. So what by ICAM I mean is intracameral anesthetic mydriatic. So it's an anesthetic, it's a mydriatic which has been used in adults. So basically what happens is, so any cataract surgery, maybe it's children or adults, would rely on the adequacy and sustenance of pupil dilatation. The success lies there because if you have a good view, you can see it. In children, the problem is more pronounced because probably the dilator muscle is underdeveloped and as compared to the sphincter pupillae. So sphincter is quite strong in children. So therefore the dilatation is tough to get. Intraoperative pupillary constriction poses a further challenge in children. So these are some of the issues. I mean, you put topical drops. There are so many times that inadvertently, intraoperatively, when you're doing an important step, the pupil wants to constrict. So conventionally, topical mediatrics have been used in pediatric cataract surgery. Now, what are the disadvantages of topical pediatric topical drops? The dosing is universal across the age group, except in infants. So you have those drops and you just put them, advise them, they have to put twice or thrice before surgery, and that's across. It's like a blanket thing. Associated systemic side effects are there because these are absorbed through the nasal lacrimal duct and the mucosa. There's a risk of allergy, which we know, toxic to the epithelium because they contain preservatives. Then children cry a lot, and so there's a washout of the drug. So the absorption in a crying and uncooperative child is also questionable. It has to cross the corneal barrier. There could be issues where you have thick corneas and you might not get a good dilatation because they have to cross that barrier. And 3 to 4 drops of drop preparation need to be used. So 3 to 4 type of drop preparation, that adds on to the cost. And of course, you have to dilute them in infants. So the combination which is available, which has been, you can say, which has changed the, you can say, the ease of doing cataract surgery in children. And of course, I mean, it's such a, you can say, it's given a peace of mind to this surgeon. What we've done over a few months is this wonderful combination of tropicamide, phenylephrine, and lidocaine, which comes by the name of Phenocaine Plus. So this is the only one which is DCGI improved and which is available in India. So it has been used in adults with good success. Standardized combinations, they produce rapid and adequate mydriasis, which has been seen a good pupillary size of maybe 7.5 millimeters after viscoelastic injection. It's a less stressful experience for the patients who might be just sitting outside and repeatedly seeing the dilatation, keep on putting drops. So it's kind of a eases out thing. So the patient is not putting those 3 drops. It improves patient flow and surgical team efficiency. These studies show that rate of capsulorhexis performed without the use of additional mediatrics had a pupil size of at least 6 millimeters, which was just prior to capsulorhexis. So that was pretty high. So that means it had a good effect in adults. No side effects were seen related to the drug. So there has been no study in children. What we did was a pilot project. I'll be showing you some of our surgical videos that we had. We used Phenocaine Plus in all our cases. So this is the first case. So this is a 4-month infant, a 4-month where you probably would have difficulty in dilatation even with drops. So what we have is just, you can see here, what is the pupil size in this? It's maybe just 1 or 1.5 millimeters probably. The child has a white cataract. It's a total cataract. So that's so it's 1.5 millimeters what we could measure. So from this 1.5 millimeters, what we injected was Phenocaine Plus, and we make a paracentesis and then inject a small amount of this drug. And you can see the dilatation, which starts almost in a few seconds. So the initial dilatation is fast, but then later on, probably what we've seen is it slows down a bit. So we use a very minuscule amount of drug, and it does dilate. So basically for a rhexis of about 5 to 5.5 millimeters, what you need is a reasonably good dilatation, which is achieved by phenocaine plus. The further dilatation can come with when you inject the viscoelastic. So it dilates, you have to wait for a few seconds probably before it achieves its maximum dilatation. And once we go further, so that's it, it's dilated much more. So probably after a viscoelastic, it does dilate. So basically you have a good size of the pupil in a 4-month-old infant when you want to perform a rhexis. So that's gone almost to 6.5 millimeters, and your rhexis would be around 5 millimeters, 5.5, and further dilates after putting more viscoelastic. So this is the beauty of phenocaine plus. I mean, you just have to inject it, get a reasonable dilatation, and then put viscoelastic and carry on with your surgery. So just to show you that there was no pupillary constriction as you would have maybe in topical drops. There are chances that there'll be some kind of a little bit of constriction, and because of that, the iris tissue can come into the IA port. So, but because of this intracameral injection, it's maintaining its dilatation. You can see here that we're performing a posterior rhexis with the same. We haven't injected anything else. We haven't used anything else, and so this is the second patient. Now this is a 5-year-old child. Of course, as I told you, it's difficult to get good dilatation in infants, but here when you have a 5-year-old child, this is what we injected, and we can see here that the pupil has started to dilate, and we can see here a glow coming and the opacification of the lens. So probably we also saw in our study also some differences in dilatation, which would be covered later on. But you can see that it's dilated fairly well, fairly quickly. And it goes on for some time. So that's just to show you that a small amount of drug is needed, hardly anything. And you can see here after viscoelastic, what a good dilatation. It's almost reaching up to the limbus. And you can perform your surgery. So that was about 8 millimeters of pupil what we got. So with that, the surgery becomes very easy because of good visibility. You have such a wide field. And just to show you that the pupil is not constricting anywhere. So this is the time when the pupil constricts, when you're doing an irrigation aspiration. And you can see here that the stability of the pupil which is being maintained, it's so well dilated. It's not constricting at all, even when you're doing the aspiration. So we'll be removing the lens matter, and you can see all around that nothing is coming, no iris tissue is coming into the ports. So it maintains the stability of the pupil during the surgery. And that stability, that dilatation is maintained until the implantation of the pupil. So it has a very good duration of effect as well. So coming to the third patient. Now this is a child with subluxated lens. Now what we want to do is, we would like to achieve dilatation and also constriction, because our plan is that the IOL has to be implanted behind the iris. It's a iris claw lens, you can say a retropupillary iris claw lens. So what happens here is, here we can't see the edge. It's hardly faintly visible, but just see the magic what happens, how the pupil dilates. We are injecting the intracameral anesthetic, the mydriatic, and you can see here immediately the pupil starts to dilate, and we can see the edge of the subluxation. And this will, as the pupil enlarges, the subluxation would become much more clearer. So without topical drops, you are getting such a good effect. Probably, I think a lot of advantages would be added to this this intracameral anesthetic mydriatic combination. So it's dilated, the zonules are visible, of course, then because we are anterior segment surgeons probably, so I just happened to do a rhexis here and remove the lens matter, because I wanted to, so the lensectomy would be done basically. So the pupil, just have a look at the pupil, it's almost reached the limbus. No other added maneuvers have been done, no topical drops have been given. It is just that small amount of phenocaine plus what we used in the beginning to perform the surgery with a good view, with a good wide view. And you can see here, it's still maintaining its dilatation. And so we removed the capsule, and we're going to constrict the pupil now with pilocarpine. So there could be issues that if you're having, it's a locally acting combination, and this is what we had. After pilocarpine, the pupil constricted readily. So just see the advantages. You are not really bothered that fine. Okay, if you have dilated with some locally acting drug, it probably might not constrict. So it helps us in such surgeries as well, where you want a pupillary constriction. This is a posterior iris clause what I implanted. Now coming to the next surgery. Now this is a patient of JI, juvenile idiopathic arthritis. So what would you do here? Would you like to have drops or use phenocaine plus? I mean, it has Syneky all around. Now it has Syneky, and if you just inject phenocaine, probably it might not work in these cases. So let's see what happened. That is it. And once we inject, that's it, what we're injecting. Now you see it would dilate from this place. So injecting the phenocaine plus, and you can see it's dilated from here and here where there were no Syneky, but where there are Syneky, obviously we'll have to release them. So once we release the Syneky all around, you can see the pupil is still dilating. It's like festoon type of a thing. So we release the Syneky. Fortunately, it was not that difficult. And that we did almost 360 degrees. And just see the pupillary dilatation obtained. We haven't used any kind of drops. We did not supplement it. We've just put that small amount of phenocaine plus at the beginning, release the Syneky, put viscoelastic, and have a good pupillary dilatation where we could do a rhexis easily and remove the lens matter. Even in such cases, the pupil is not constricting. Even with the margins, which are, you can say, a little floppy, it's not coming into the center. So it's the stability which this drug gives is just remarkable, absolutely remarkable. I mean, so this is the IOL implantation, what we were doing in this patient. Obviously, we performed the optic capture in this patient with the oblong rhexis. But yes, even at the end of the surgery, it's still you have a good, reasonably good view in a patient with uveitis who's got posterior Syneky, what we just released. This is a patient. Now the next patient is a traumatic cataract with ectropion uvea, where again the dilatation would become difficult and sometimes may not dilate that properly with the topical drops. Now if we have a targeted delivery which we achieved with the phenocaine plus, probably it might have some advantage over the other and help in getting a reasonably good pupillary size. So that's what we injected, and it's dilating. So sometimes you have to wait. Obviously, every case is different, and it's dilating. So it's taken time, but it's dilated quite well. And once we inject the viscoelastic, see the dilatation. I mean, I'll just go back. That's the dilatation after viscoelastic. So the start is very good with this phenocaine plus, and the rest of the things your viscoelastic does. And when you are removing the lens matter, you can see it's such a well dilated pupil. There is no constriction of the pupil at all intraoperatively when you're using the irrigation and aspiration. So that's so these are the advantages what the intracameral injection has. I mean, just any type of case, you have uveitis, you have this traumatic case, you have infants, you have young children. The amount of dilatation, you can see, and thereby increasing the ease of the surgery. It is basically it gives us so much with such a little amount. You can achieve such, you can say, it has such a big advantage over the drops. And so basically, I'm just showing this video to show you that the pupil isn't coming down at all. You can do a posterior rhexis, go ahead, do the optic capture. So basically in the optic capture, we have to see the optic haptic junction, and we can still, so it's so well dilated, we can even see the optic haptic junction. And obviously the oblong capsular rhexis signifies optic capture. So this is another child. Now this is something, obviously we don't find that so common in children. In adults, yes, floppy iris is quite common. So this child had bilateral cataract, and so when we operate did the first trial, we had used topical drops. Now, yes, you can see here the dilatation achieved with topical drops is so reasonably, it's quite good. I mean, so but the child has a white cataract, and we have to perform a surgery. We don't know what the child is going to have, how the iris is going to behave, what is the pupil size. So you have really a 7.5 millimeters pupil to start with, and that's reasonably good. So on all surgeries, obviously, we make these ports. These are the side ports what we make with the 15 degrees knife. So that's one side, and then probably we did not go the whole length in. So both these side ports are made. And we had a plaque here. So we're trying to remove. So it was a type of a complicated cataract, which obviously the anterior capsulorhexis could not be done without Rata forceps, but we had to use a cutter to remove these fibrotic plaque, and then obviously we do a rhexis along with. So what happens here is the iris is trying to come out now, and there is some, you can say, billowing of the iris in between. This iris. So that's the irrigation aspiration when you're doing. So there's the cutter when we're using. So whenever you're using some kind of an aspiration, probably that's the time when your iris is going to behave abnormally. In all cases of in all children. So we're trying to. So that's what we had. We could do a vitrorhexis, but you can see here the pupils come down. There's iris prolapse which is occurring. Is becoming difficult for us to perform a surgery. Now this is done under topical drops. So this is a child with floppy iris where the pupil constricted, there was some iris prolapse occurring. So after removing the lens matter, we dilated the pupil with viscoelastic. It did dilate. Now when you're trying to do the rhexis, posterior rhexis, again there is constriction of the pupil. So these are some of the problems where you cannot predict which child is going to behave, how the pupil is going to behave, how your surgery is going to be ultimately affected. You can see here the pupil has come down drastically with these drops. Of course, we did do a clean surgery finally, but yes, just to show you that what is happening with the drops, that's the pupil. So how difficult it becomes intraoperatively with the drops in a few cases in children. So the other eye, because we diagnosed him as a floppy iris, we thought maybe we'll yeah, so that's the other eye of the patient. So here what we are doing is we are going to use phenocaine. This is a constricted pupil. The size is hardly about 1.5 millimeters, and we're using phenocaine plus here. So we're going to dilate this pupil and see how it behaves. Because of the floppy iris in the other eye, we did not want to do the same thing in the left eye of the child. So it's dilated fairly well, and I'll just move forward. It's dilating, and that's it. So after viscoelastic, it's dilated fairly well. So again, the child has a plaque, and then, sorry, just went on. So that's it. So basically, we've done the eye. The pupil is not constricting. There is no prolapse of the iris as well. So in this eye, we had used just phenocaine plus, and you can see here how well maintained you can see the surgical view is, as compared to the other eye which constricted intraoperatively. So this drug really has so many advantages. I mean, it's worthwhile to use it in children because they are difficult to dilate as compared to adults, plus the intraoperative issues which can come up with topical drops, the systemic side effects which you can have. Probably you can use it like you can use adrenaline in the bottles. Again, it has to be diluted and used, or and obviously in every case probably then you would be using that. But when you have something which is so easy to procure and just requires a minimal amount of you can say just a minimal amount of drug is required to be injected, probably I think it has its own advantages, and I think we should prefer this over using adrenaline in the bottle. This is one more case. Now, what happens in ophthalmos? We have large corneal diameters, and of course, sometimes what happens is you have difficulty in dilating the pupils. in cases of ophthalmos or maybe anterior megophthalmos. So we've injected this phenocaine plus. Sorry for this. It's some air bubble was there, so injected. But you will see how the pupil is dilating. So you can see here it's going beyond this air bubble, and it's working really fast. So this was an older child, but yes, I mean, it's something you have readily available. Just get it and inject it, and it works wonders. So I'll just forward this, because otherwise it's going to take time. So we can, just to show you, this is the cholesto markings, and you see we've achieved almost, you can say, 7 millimeters of pupillary dilatation. I mean, so 7 millimeters just with the small amount of intracameral drug. It's a fairly good dilatation what we achieve. So it's almost went to 9 after viscoelastic injection. So when irrigation aspiration is being done, you can say the size of the pupil is being maintained. There is no constriction of the pupil in such cases. So that's the beauty of this drug. So there's number of conditions. I mean, it just works magic in almost like every case. So the IOL was being implanted and it still maintained the dilatation. You can say the pupil has not constricted. So that is a small amount of drug is working for quite some time. Now coming to the last video, this is a patient, you can say an infant probably, who was dilated with topical drops. Now the dilatation achieved was not significant. We wanted to have more, because we were dreading that with this the pupil might constrict intraoperatively. So with this, what we did was, we thought we'll inject some intracameral anesthetic and just see how the pupil is dilating. I mean, you can see where it's going. So even when you use topical drops and you want to add on, you can use this intracameral magical solution and it will work wonders. It's going to give you a stable pupil where you can do your surgery with ease. You won't be bothered about pupillary meiosis in between the surgery. And for the duration of surgery, whatever is required when you're doing pediatric cataract surgery, it maintains the dilatation. So that's the IOL being implanted, and yes, it maintains the dilatation till the end. So basically what we saw was that we had a size of at least 6 millimeters achieved in the majority, and it was sustained. So the important part is it's sustained. There were no systemic side effects. And this was a good paper, I mean, which was published in European Journal of Ophthalmology, and it is by my faculty colleague here, Dr. Savleen, who will be talking about this. I mean, it was, so in a few patients, we did the study, and the beauty is, I mean, if you see, it's date received 3rd March, accepted 9th March. So it was such a novel idea. It's written so well, I mean, that we didn't have in this original article, I mean, accepted within 6 days is something like, obviously, we were really proud of. So this paper would be discussed by Dr. Savleen now, who's done commendable work in pediatric ophthalmology, and the way she writes papers, I mean, you can see the acceptance within 6 days. So now I'll request Dr. Savleen to kindly share her screen, and then I'll come back again. Savleen, you need to unmute.
Good afternoon, everyone. Good afternoon, sir. Thank you so much for inviting me today. And it is all your work, and I'm happy to be sharing this podium with you and presenting this work, which I think is all yours. And so the paper was about intracameral anesthetic mid-diatric assisted pediatric cataract surgery. And as already described by sir, it was published in the European Journal of Ophthalmology. So the background is, I think the foundation has been laid. The success of a pediatric cataract surgery will depend on the intraoperative pupillary dilation and the mydriasis, and how stable mydriasis you achieve during the surgery. The topical dilators are not often weight adjusted, and you deal with kids who are ranging from say 1 month to 10 years. And so how much drop to use and which one, it's not really titrated. So mydriatic effect of these drops also tends to wane off, because we use the standard doses in almost all age groups. So with this in mind, we planned the study, where we used phenocaine plus, again, no financial interest. It's an anesthetic combination of phenylephrine 0.31 tropicamide 0.02, and lidocaine 1% for pediatric cataract surgery. It was a pilot study, so we consecutively enrolled pediatric patients after taking an informed consent from the parents and, of course, an institutional ethics board approval. We included all sorts of, all ages of children less than 12 years with the visually significant unilateral or bilateral cataract who were planned for surgery. And we just ensured that their pupil dilated whenever we examined them in the clinic and excluded those who had hypersensitivity to the drugs or in the combination. Those who had any pupillary abnormalities, any synechiae, any glaucoma, we excluded those for the pilot study. We did the routine preoperative evaluation as any case of pediatric cataract. And we intraoperatively, of course, we did not use any drops preoperatively in the operating room when we started with the surgery. We measured the baseline horizontal corneal diameter with the help of a castrovisual caliper and then proceeded with the standard surgery. And the first step was that we made a clear corneal incisions. We have already seen the video. And then after doing this paracentesis, we injected 0.025 ml of phenocaine via a tuberculin syringe into the anterior chamber. We waited for approximately 60 seconds for the pupillary dilatation because that was with experience that we thought would be adequate time to get a adequate pupillary dilation. And in cases where we saw that it was not adequate enough for the surgery to be carried out, we injected a double dose and waited for another 60 seconds. Of course, we noted the time that it took for the pupillary dilatation to achieve the maximum that it could. We took screen captures because we recorded all videos. The rest of the steps were the same in any standard pediatric cataract surgery. Depending on the age, the primary posterior capsulotomy and the anterior vitrectomy was done. But by and large, after the recording was complete, an independent person, an independent observer, took screen captures from the videos at 5 time points. At the start of the surgery, after injection of phenoclaine, and then after viscoelastic injection, just before intraocular lens implantation, and at the end of the surgery. Where intraocular lens was not implanted, the end of the surgery was the time point that was considered. Now you see these are snapshots which are taken at the required time points and exported to the ImageJ software. Now we knew from the castrovisual caliper what was the corneal diameter, which was pre-measured, and we fed it in the software as a scale. And then pupillary dilatation was automatically computed from the software so that we have a standard calculation and the observer did not know what the surgery was and drug was used or not. So representative photograph of how dilatation was measured, and this is the corneal and this is the pupillary diameter as shown. We had recruited around 16 eyes and they were all age range 1 month to 10 years and equal distribution of right and left eyes. We also did have 4 patients who had microcornea. Average time for the whole surgery was also noted, and average time for pupillary dilatation, which was in fact the most important point, was around 60 plus minus 13 seconds. This is a table showing all the patients, and you can see that the corneal diameter ranged from 10 to about 12.5. And these were the cases who had microcornea, the ones that are marked with this symbol. The axial length was again, we had patients who had microphthalmos as well. And at every time point, the mean pupillary dilatation from the ImageJ software was calculated. We also tried to see how much the pupil changed over time and how much the pupillary diameter variation was noted during the surgery. So the mean pupillary dilatation increased from about 1.9 at baseline to about 5.68. So keeping in mind, we had cases of microphthalmos as well. So this is 5.6. That's why we get this as a mean value. And there was a correlation between the pupillary diameter and the baseline pupillary diameter, and of course the axial length of the patient. There were 75% patients who had a pupillary diameter of more than 6 mm at all time points of the surgery. And if we exclude the ones who had microcornea, we had a pupillary dilatation of 6.6, which was very good as a mean value. So again, a representative photograph showing how the pupil dilatation was maintained throughout the surgery, how the pupillary dilatation in fact increased towards the end of the surgery, and most importantly, we did not observe any intraoperative miosis in any of these patients. In all these patients, we could complete the surgery without any supplementation, And there was this consistent increase in the pupillary dilatation throughout the surgery. If you look at the variability also, the pupillary size never dropped. This graph is showing how it kept on increasing and almost maintained to about 6.6 to 6.8 towards the end of the surgery. Again, reiterating, there were no cases of meiosis, no cases of iris bleeding, damage, or floppy iris noted. And the mean variability was around 1.5 mm, which was clinically kind of insignificant. The average change in pupillary size from injection till the end of surgery was positive. So no patient had a drop in the diameter of the pupillary measurement till the end of the surgery. We did do augmentation of the drug in 2 cases because we thought that the pupillary dilatation was not adequate. But once we augmented the drug, we saw that the change was only about 0.6 mm. So double the amount injection also did not bring about a significant increase in the dilatation received. We did not have any cases of blood pressure abnormalities because these patients were all done under general anesthesia. So these systemic factors were being monitored. Post-operatively also, there was no case of corneal haze or inflammation or raised IOP that we saw. We did feel at that time point that we had less number of patients and we did not have a comparison now. So I think that's the future. That's what we are planning, and we plan for a randomized study where we can compare the topical standard modality versus this newer and effective intracameral combination of pediatric and anesthetic. So we concluded with the study that prompt and stable mydriasis was achieved in children with intracameral injection, and coupled with so many advantages that Dr. Jaspreet has so nicely elaborated with all the videos. And that also with a minuscule dose, we recommend this paper recommends this as an effective and safe alternative to topical drops. Again, thank you, Dr. Jaspreet, for your unconditional support and for bringing these kind of opportunities my way. Thank you so much.
Thank you, Savleen, for that wonderful presentation and the hard work you've done to get this paper out. So I'll just conclude in a few slides by just the last 2 slides. So this is what being discussed by Savleen now. So basically what we saw was that adequate and stable mydriasis is achieved with intracameral anesthetic mydriatic combination, and which is obviously only available is Phenocaine Plus. I still call it and I still repeat it that it's a magic bullet for the pediatric eye. So the advantages are targeted drug delivery, new ocular surface toxicity or systemic side effect. You're doing it with all those preservative issues. In COVID times, you don't know when the patient is taken up, GA sometimes delayed, sometimes so all these things add up because you put dilators and the patient is delayed, probably you would lose some amount of dilatation. Prior gonioscopy possible in an undilated pupil. So that's the advantage. Even though we don't do surgery at that point, but yes, in case where it's required, probably you could do gonioscopy because the pupil is not dilated. Even in those who are allergic to atropine or cyclopentyl, it's a very good alternative. And it's cost effective. You're not using 3 drugs, which will cost you maybe about 300 rupees. It's just a simple one, probably costed less than 1/3 of the price, and delivering something which is quite fast. So that's the beauty of the intracameral anesthetic mediatic when you use it in children. And yes, I'd like to thank Entod for this, for bringing out the Phenocaine Plus, which has really changed the way pediatric cataract surgery is done.